Welcome, everyone. I'm going to get us started. We want to make the most of our time. And if you've attended one of these before, you know I start with some general information about our program to let people filter in, usually as they're getting out of morning clinic or other meetings in the morning. Um, Regardless, welcome everyone to our Dementia Care webinar, Dementia Care Aware webinar for June. Our topic today is dementia and the Asian American and Pacific Islander population. A slightly, almost 2 weeks, slightly delayed presentation for what last month was AAPI Heritage Month. And of course, this is a really important topic for us in general, but in California. So we're really excited about this webinar and particularly about our presenter, Dr. Elena Tsoy, who's an assistant professor of neurology here at UCSF in the Memory and Aging Center. I'm going to say more about her work in a second. So she is a bilingual neuropsychologist here, and her research really focuses on disparities and equity in diagnosis for people living with Alzheimer's disease and related dementia. She's also going to, of course, have a chance to say more about her work as we go forward. And many of you know me, I'm the executive director of Dementia Care Aware, and I'll just be moderating our session today. A little bit of housekeeping as we get started. We will leave time. We should have plenty of time for Q&A at the end, but as we're going through, please put your questions in the Q&A. I will, or the chat, whichever works for you. Q&A can be a little bit better because it's a little more readable for everybody, but we love to see your questions. I will answer them if I can in the moment, but then at the end, we'll have time to go back. Often I can consolidate them and we can have a good conversation. So we always really appreciate your questions. Please keep those coming. Right at the end as well, around 15 to 10 minutes to the end of the hour, we'll post information about how you can claim your continuing education and continuing medical education credits, and you'll get that information by email as well. We put everything up on our website. This is being recorded. We'll put the slides up there as well within 48 hours. So if you're furiously taking notes or wondering if that's possible, it's definitely possible, and we always do it. So we look forward to you rewatching or going back and looking at the materials or recommending it to others. And we also will have everything, as you know, on our website and our YouTube channel. As often, we like to just briefly go over all of our offerings. We are still doing a ton of training every week. We have lots of educational modules that are live, which I'll mention in a minute. And then, of course, we have all of our online offerings. We have ECHO conferences, which many of you are enrolled in. You can get information about that on our website. We have our warm line, 9 to 5, Monday through Friday, if you want clinical advice about dementia care, especially about screening, but anything having to do with dementia clinical care. And then we have our practice support champions and consultants through Alzheimer's Dementia Care Program and the Alzheimer's Association. If that was too much to absorb, you can always contact us at our email here, dca@ucsf.edu, or just go to our website for more information. As you know, our core training about the cognitive health assessment is online, and you can get more credits that way or learn more about how we train to do the cognitive health assessment, which is a screening approach for primary care. And as many of you have seen, we start with a 3-step approach that we recommend all patients who don't already have a diagnosis of dementia have a screen every year, and that this screen can be quickly done with a brief history, very often just one question, using a screening tool for cognition and function, and then having a brief question or conversation with the patient about if there's anybody in their life that plays a care partner or caregiver role. And you can learn how to do that in all the materials through our training modules or our website and webinars. And finally, we are still doing many, many live trainings, which people really like because they can ask questions, and they're often a little more dynamic than the online training. And they're all free and have credits, CE, CME credits as well. So please tune in. Again, there's always the opportunity to sign up for those pretty much every week, including during the summer through our website. So thank you so much. Now, I'm really, really pleased to transition to our presenter, Dr. Tsoy, and please, I'll fade out into the background here and really keep the focus on you and look forward to seeing you again for our questions. So please take it away.
Thank you. Thank you so much. And thank you everybody for being here. I'm really excited. I think this is the second time I'm doing a webinar for this program, which is so, so important. And I'll start with just my financial disclosures. I get research funding from NIH, the Alzheimer's Association, and the Global Brain Health Institute. And the work that I do is also supported by additional grants that I am not the primary investigator on. Next slide, please. Great. So in terms of learning objectives, I think I try to sort of summarize some of the learning objectives, but I also would love to have a conversation around what are most important learning pieces that I'm sure I will probably go over it a little bit too quickly, given just how big this topic is. But I'm hoping we'll be able to cover the general cultural, linguistic, and socioeconomic diversity of the population of Asian Americans and Pacific Islanders in the United States. We'll recognize some factors associated with cognitive impairment and dementia risk in this population. We'll discuss considerations for conducting dementia assessments, especially cognitive assessments, with Asian Americans and Pacific Islanders, and also identify gaps in future directions for advancing dementia care and research. I won't spend too much time on that last point, but I wanted to give you some resources and some pointers as to the types of research that is happening right now and is sort of rapidly evolving, just given how important the current state of empirical evidence is just so limited in this population. So I think I wanted to start with background terminology because there's a lot of conversations around, Asian American Pacific Islander identity. This is definitely not a monolithic group. And unfortunately, given the historical sort of data collection and aggregation of different racial and ethnic and cultural groups in research, including research like research using census data, something that we use all the time when we try to run population level studies, or especially in my work that specifically relates to disparities in healthcare. So the most common standards for reporting race and ethnicity are the ones modeled or consistent with the categories that are specified by the U.S. Office of Management or Budget, or OMB. And currently in research literature, there is no consensus regarding what is the appropriate aggregation and whether aggregation is even appropriate altogether when we talk about the populations that have been historically defined as Asian American Pacific Islander, or API. In the older versions of the US Census, this population was referred to as Asian Pacific American, or API. And then I think most recently, there has been more and more push towards more inclusion. So I think that's the category that I'll be using most, because it's kind of, again, as I said, it's an emerging way to talk about these populations. And this label is Asian American and Native Hawaiian and other Pacific Islander, or AANHOPI. And the most recent updates to race and ethnicity standards were published actually very recently in March of 2024, and they defined Asian Americans or Asian populations as individuals who have origins in Central or East Asia, Southeast Asia, or South Asia, and include, for example, Chinese, Asian Indian, Filipino, Vietnamese, Korean, and Japanese. I also think it's important to highlight that Asian population globally is actually the most populous kind of group of people residing on this planet, and 60% of the world's population resides on the Asian continent. Native Hawaiian or Pacific Islanders are individuals with origins in any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islands, and include, for example, Native Hawaiian, Samoans, Chamorro, Tongan, Fijian, and Marshallese individuals. Next slide, please. And yeah, please. I'm sorry, I added these animations. There you go. So in terms of just general description of the Asian American and Native Hawaiian and other Pacific Islander population in the US, these are the 2020 US Census Bureau estimates. According to that census, 24 million Asian Americans resided in the US in 2020, with the most prevalent groups being Chinese, Asian Indians, Filipino, Vietnamese, and Koreans, and 1.7 million Pacific Islander and Native Hawaiian residents. And the most kind of the largest subgroups within that community include Native Hawaiians, Samoans, Chamorro, Tongan, and Fijians. Next slide, please. Great. So I wanted to go over this, the reasons why data aggregation and overgeneralization are really insufficient in order to be able to provide both scientific evidence, but also kind of understand the gaps in the healthcare provision to these populations. Many recent studies highlight the limitations of generalizing research findings, especially from that kind of older historical version of the US Census that used the API, Asian Pacific Islander category. For example, consider the study that was published in The Lancet a couple of years ago. This is a group of collaborators who worked on trying to model life expectancy in the United States and the trends in changing life expectancy over time using the old census data. And if you look at let's look at the green line, which sort of includes the non-Hispanic white population. And you can see that, the trend sort of remains almost flat over time, whereas the life expectancy in Asian or Pacific Islander, that pink line on top, really, if you looked at this graph, you would think, oh, Asian Pacific Islanders actually have greater life expectancy, and it appears to be on the increase. But there is also an associated commentary to this article that I highly, highly suggest that you read, by Tapara and Pellegrin, referenced here, where I think one of the most important quotes which summarizes that commentary is that the author's systematic erasure of known disparities within the Native Hawaiian and Pacific Islander community through the use of aggregated API category obscures the truth and reinforces the marginalization of these indigenous people. And there is evidence to back up this claim. For example, studies done in Hawaii show that Native Hawaiians and Samoans have the shortest life expectancies of Hawaii's 7 major ethnic groups. Native Hawaiians and Samoans on average have 9 to 13 years shorter life expectancy compared to the Asian populations that reside there, like Chinese, Japanese, and Korean, and 5 to 8 years shorter life expectancy compared to non-Hispanic white and Filipino populations. And also, if you consider the median age of the population as sort of an indicator of life expectancy, the median age of Native Hawaiian and other Pacific Islanders in the US is 10 years younger than for the general US population as a whole. So 27 years versus 38 years. Yes, next slide, please. Thank you. So I think in order to try and hopefully do at least a certain degree of justice to these populations, I wanted to review the evidence that we have about dementia in these populations by separating Asian Americans and also Native Hawaiian and Pacific Islanders, and sort of highlighting the evidence that currently exists. So Asian Americans are the fastest growing major racial and ethnic group in the United States, especially among older adult populations, especially in California. I cannot stress this enough. The majority of Asian Americans in the US reside on the western side of the country, and most people who live in the West live in California. So you can see the sort of projected increase in the Asian population in the US, as based on the census data. But Asian Americans are also expected to become the largest immigrant group in the United States over the next few decades, and they will surpass Hispanic immigration into the United States. I think this is critically important because when we review sort of evidence about the immigration patterns, it's the nature of the social determinants of health and sort of socioeconomic situations that force people to immigrate differ greatly over time and also between different ethnic and cultural groups. Next slide, please. Thank you. Great. So Asian Americans, as you can imagine, are extremely diverse in their nations of origin, the languages that they speak. They represent over 50 ethnicities and over 100 different languages and dialects or localizations of language. The majority of the US Asian American population is represented by Chinese, Filipino, Indian, Vietnamese, Korean, and Japanese ethnicities. And US-born Asian Americans are more likely to be younger than foreign-born Asian Americans. I think this is critically important for us to know when we work with older adults, and especially when we are trying to detect dementia. I think it's important to have that appreciation of the fact that the cultural background, as well as sort of perception of dementia and perception of health and health literacy differ widely, even within Asian American communities and within certain racial, ethnic, or cultural groups that you're working with. So if you're working with older adults, they are more likely to be immigrants. They're more likely to not be sure how to navigate the healthcare system, and they might need a lot more education around dementia and sort of the way that we conduct these assessments and the purposes of these assessments. And another important factor, of course, for any type of cognitive testing is language proficiency. So self-reported English proficiency varies widely across different ethnic groups in the United States, and also by nativity status. So if you look across ethnicities, 85% of Japanese adults, this is just including adults altogether, not just older adults. So 85% of Japanese adults say that they are proficient in English. 84% of Filipinos say that they are proficient in English, but compare it to, for example, 36% of Bhutanese and 38% of Burmese Asians in the United States. And then, as I mentioned before, proficiency also varies widely by nativity status. So foreign-born Asian Americans, especially older ones, are much less likely to be proficient in English. And it's also important, I think, to consider the context and the sort of geographic location from where people have immigrated, because even if you consider something like this wonderful graph by the Pew Research Center here, doesn't actually indicate whether, do they speak Mandarin Chinese? Do they speak Cantonese Chinese? Do they speak Taishanese Chinese? Other specific dialects that are available, because there are a lot of variations in language, and language is critically important to gauge somebody's cognitive abilities, because most of our tests do use language stimuli. I think it's very difficult to talk about Asian American populations and sort of the types of disparities they may experience in care without mentioning the model minority stereotype. So the model minority stereotype is sort of this idea that, it's the stereotype that perpetuates that Asian Americans are very well positioned. They are the model immigrants. They are able to adjust to different settings. They're very hardworking. They have achieved success in this very, very complicated system in a new country. And again, if you have the time, I highly, highly recommend that you actually refer back. So the earliest mentions of the model minority myth, or sort of the origin of it, is usually related to these two articles published in 1966. One in the New York Times Magazine about Japanese Americans, and another one in the US News and World Reports on Chinese Americans. And the reason why I think it's so important for us to learn about this history and to understand it is because by reading these articles, I think you recognize how easy it is to generalize, these certain kind of ideas about how huge groups of populations that are extremely diverse within their communities are perceived especially on the political level. And so when model minority myth is extended to health, it perpetuates the idea that Asian Americans are well positioned with regard to their health status and their health access, and therefore are not disadvantaged in relation to their health care, nor are they underrepresented in health studies. However, as you probably can gauge from the way that I talk about it, model minority stereotype is really a myth, because first of all, by aggregating all 8 different communities within the Asian American community, it masks the disparities that exist within this non-monolithic group of people. And Asian Americans actually have the largest within race, or within category, income divide, as well as the divide between poverty rates across different ethnic origins. Educational attainment, which oftentimes is also a part of that model minority stereotype. If you're Asian, you did well in school. If you're Asian, you have high education, you probably came from a family of doctors or lawyers or engineers. But educational attainment, again, in the United States varies widely. 75% of Indian adults, for example, have a bachelor's degree. This is only compared to 15% of Bhutanese individuals, right? So if we, again, combine everybody together and just presume that this is a monolithic group, we are really making false judgments around the health and as well as health disparities within this population of people. There are massive health implications to model minority myth as well. Again, without disaggregating data, we might be making conclusions like that study about life expectancy that I showed you just recently. For example, cardiovascular health disparities are well known, and especially if you look at the actual ethnic and cultural groups within Asian American community, you'll find, for example, that despite on average the Asian Americans having lower rates of hypertension and heart disease mortality, many Asians have greater disproportionate mortality from hypertension, especially when compared to non-Hispanic white population, like Chinese women, Filipino women, Asian Indian women, Korean women, et cetera, et cetera. So the risks may differ widely and would require a much more different approach to providing healthcare as well as counseling to these patients if we are to understand this data better. So I really love referencing the study because I think it also highlights that, beyond looking again at these kind of ethnic categories or countries of origin, it's important for us to consider the social determinants of health and really the economic variables that we know underlie a lot of health disparities. So this study used the data from the National Health and Nutrition Examination Survey, and it included about 3,000 adults aged 60 and older, across different racial and ethnic groups as defined by the U.S. Census. And they looked at at how living in poverty impacts these different outcomes that are important for overall health in older adults. So they looked at ADL disability, IADL disability, depression, and cognitive impairment. And you can see that, the kind of living in poverty puts you at greater risk across all groups, but look at the degree to which that discrepancy exists within the Asian community. If you just look at the black bars, Asians living in poverty are much more likely to have disability, both in instrumental and basic activities of daily living. They're more likely to have depression, and they're much more likely to have cognitive impairment. In terms of dementia epidemiology, there remain significant gaps in our knowledge and understanding of the prevalence, incidence, as well as risk factors for dementia in Asian American populations. And I think one of the key reasons for it is that lack of disaggregation. If we don't disaggregate populations, we're really kind of drawing very, very broad conclusions without actually understanding whether there is any variation between different communities with very different social, cultural backgrounds and immigration patterns. And so I think most recent research is trying to address these results. So please take these projections with a grain of salt, because again, they have been published using historical data with no significant degree of disaggregation. But I do also want to highlight that underrepresentation of Asian Americans and Native Hawaiians and other Pacific Islanders has persisted in NIH-funded research, at least for over 25 years. So over the last 25 years, only an average of 0.17% of the NIH budget was focused on research that involved Asian Americans and Native Hawaiians and Pacific Islanders, but was not actually focused on these populations, despite the fact that, once again, these populations are the fastest growing minority group in the United States. There's also considerations about, there are a lot of studies published in China or Japan or Korea, and less so in Vietnam or, Southeast Asia. But why can't we just extrapolate findings from there about the dementia risks and the prevalence? And I think it's a very, it's not a very reasonable thing to do, primarily because there are such substantial societal, economic, and cultural differences between populations that are Asian American versus Asian residing in Asia, and the types of the healthcare systems within which they operate, and also the kind of cultural knowledge that people have when they reside in a country where they were born versus when they immigrated, or they might not have proficiency in a local language in. So in terms of prevalence studies, there was a recent systematic review that summarized 45 studies and reported an average prevalence of dementia within the Asian American community, specifically of about 10.9%, which is very consistent with overall rates reported in the general population. However, the important part that this systematic review highlighted is the range of the studies on prevalence. So the range was massive, from 0.4% to 46%, and if you're a scientist, you're thinking about these numbers and you're very frustrated because, this really tells you nothing, and how valuable and, how valuable these data are for you to be making conclusions or for you to be trying to estimate risk is questionable. And again, the authors highlight consistently that this range likely is a result of the fact that the populations that were studied are very, very different, beyond just biases that exist when people decide to participate in research, but also because of the way the data have been aggregated and the way that we have been collecting race and ethnicity categories. In terms of incidence studies, same systematic reviewer reviewed incidents, and they reported an average incidence of about 20 cases per 1,000 person years. And again, the range was massive from 75 to about 14. Another study that looked at about 20,000 Asian Americans who were Kaiser Permanente Northern California members, age 64 and above, and followed for over 14 years, reported for the first time ever that there are differences in incidence of cognitive impairment between different groups that belong to the Asian American kind of racial and ethnic category. And you can see that little graph there. The references are all included. And so if you're, if you're thinking about learning more about it, I think it's important to also highlight that the limitation of the study is that they focused on the largest groups just to be able to power their analyses. So they included Chinese, Japanese, Filipino, South Asian, and then just other unknown Asian category, which once again is better than what we used to do, but still doesn't truly reflect the diversity within that community. Okay, so what about risk factors? I think the research on risk factors has been sort of growing more to the global scale, and we now know that there are certain risk factors that underlie cognitive impairment across many different cultures. So, we're all humans, we share most of our genome, and so we know that the social determinants of health and lifestyle factors actually exert presumably even a stronger effect than some of the genetic factors that we have studied over time. And in terms of different kind of subcategories of what we would consider as factors, they are typically reported across different populations, but also have been reported in Asian Americans specifically. For example, demographic and social factors that might put somebody at a greater risk of developing cognitive impairment or dementia include older age, lower education and income, and certain occupational factors, like, for example, workplace safety and conditions and high exposure to physical labor. Midlife vascular health has been consistently reported as a potential as conferring risk for development cognitive impairment in later life. And these indicators could include things like higher BMI, hypertension, sleep apnea symptoms, especially if they're not addressed, and impaired glucose tolerance. And then another kind of set of variables or set of factors that we always consider when we do these assessments are late life comorbid conditions, or conditions that are present at the same time as you're detecting cognitive impairment. And these include cancer, type 2 diabetes, different cardiovascular diseases, as well as depression, which is especially relevant in the Asian American population. And furthermore, current research and some of the studies I will highlight later in this talk really tries to focus on the roles of the factors that we haven't been historically capturing, trying to understand whether the role trying to understand the role of immigration history, or, for example, early life adversity for a lot of Asians who have migrated to the United States as refugees, maybe following, conflict in Vietnam or Cambodia. Acculturation stress is a huge factor. There has been a lot of research focused on COVID-related disparities and the insane levels of discrimination that the AAPI community has faced because of the pandemic. And I think all of these factors are incredibly important for us to understand better, because we will be able to tailor our interventions as well as our assessments to individual populations to provide more person-centered care. So we'll switch gears a little bit, and now I'll go over some of the kind of population overview and studies on dementia in the Native Hawaiians and other Pacific Islander populations. So NHOPI are individuals from nearly 30 island nations across 3 geographical regions of Oceania, typically including Melanesia, Micronesia, and Polynesia. And the cultures, languages, histories, and voyaging heritage are very distinct among NHOPI compared to the peoples of Asia. Largest subgroups, as I mentioned before, in the United States include Native Hawaiians, Samoans, Chamorros, and Micronesians. An important thing to consider is the fact that when we think about longevity and sort of life expectancy, and the greater life expectancies usually confers greater risk for ADRD because age is the main risk factor. Unfortunately, due to historical a lack of access as well as health disparities in an NHOPI community, it is estimated that older adults actually comprise a lower number or a lower proportion of these populations compared to, for example, general US population. For example, among people in Guam, only 5% are older adults, less than 4% of American Samoan population are older adults, and about 13% of Native Hawaiian populations are considered to be older adults. However, some research has been conducted, and it highlighted that NHOPI older adults have among the lowest per capita incomes and highest poverty rates of all older adults residing in the United States, regardless of the ethnic group. Another, I think, common misconception is that, the populations that are included within the NHOPI community are fluent in English because they have been residing in these areas for a very long time, but this is absolutely not true. English is not the first language of about 46% of NHOPI elders, and 14% of NHOPI older adults report they do not speak English well at all. Some important considerations. So we reviewed sort of the model minority myth that I think is an important consideration when we think about Asian populations in the United States, but there are very, very important considerations and the historical aspects that might help you better understand and work with NHOPI older adults. So if you when we talk about Asian American populations, I mentioned that, Asian Americans are underrepresented in research, when you compare to sort of their overall proportion in the general population and the proportion that is included in research studies, they are underrepresented. So if underrepresentation of Asian Americans in research is terrible, then representation of NHOPI older adults in research is dismal. It is absolutely, they are probably one of the most underrepresented ethnic and cultural groups in ADRD research. It is very, very difficult to find any scientific evidence on the NHOPI community when it relates to any aspect of dementia epidemiology. Even fewer studies have included, for example, languages that are spoken among the NHOPI community and try to develop tools that would actually be consistent with the languages they are most proficient in. I also think it's important to highlight the differences between NHOPI and Asian populations in terms of their historical experiences. By contrast to the immigration histories of Asian populations, Native Hawaiians and other Pacific Islanders usually share a history of trauma and oppression through the process of colonization. So, for example, the first contact with European people in Hawaii precipitated the near complete erasure of the Native Hawaiians, with more than 95% of the population killed by foreign diseases. So if you want to consider this history, I think you could potentially draw, analogies between NHOPI communities being sort of more similar in their history to Alaskan Natives and Native Americans in their perception and sort of, integration within what we consider now the United States, compared to Asian Americans who are sort of more classic immigrants in a sense. Some research, again, not focused specifically on older adults, but generally within these populations highlighted higher rates of chronic diseases, including obesity, diabetes, kidney disease, substance use disorders, and other conditions compared to Asian populations that reside in similar areas as NHOPI adults. And more and more research is coming out now, especially knowing that all of these factors listed here could potentially be risk factors for development of cognitive impairment and disability in late life. Many of these are likely related to significant differences in social and economic capital and well-being of these populations. For example, Native Hawaiians in Hawaii have highest rates of high school dropout, e-cigarette use, adolescent suicidal ideation, uninsurance rates, poverty, homelessness, and incarceration, even though they're living on their own land. And across Oceania, Indigenous Pacific Islander populations are consistently reported to experience worse health disparities, including lower life expectancy compared to non-Indigenous populations. And these are the studies that are not just conducted on the territories that are included within this sort of US census, but also research conducted by Australian researchers and researchers in New Zealand. As I mentioned before, because of the dismal underrepresentation of Native Hawaiians and other Pacific Islanders in dementia research, we don't actually know that much. The only study that I have been able to find, and the one that is referenced, over time in literature, is a population-based survey of Chamorros, age 65 and older on Guam, that suggested a point prevalence of all-cause dementia of about 12.2%, including 8.8% of Guam dementia, which is basically clinically equivalent to Alzheimer's disease. It includes sort of a memory cognitive presentation. And this study was conducted in 2004. And just to give you an idea, it was 20 years ago, and this might be the only sort of population-based study that was conducted specifically in NHOPI community. No studies have been conducted on the incidence of ADRD, sort of, the risks and the rates at which we believe the disease, people develop disease over time. There are 2 reports on dementia incidence from Australia that was conducted in Aboriginal and Torres Strait Islander peoples. And I kept the wording, this is not my wording, I just want to say this is the wording that was reported in the paper. And they found higher incidence rates of dementia in these communities, ranging from 21 to 36%. And this is a higher rate compared to white Australians. Next slide. Okay, great. So as we talked about when we reviewed risk factors in Asian American populations, most review studies do suggest that risk and protective factors associated with dementia are likely congruent with the evidence available for non-Indigenous populations. But given known health and healthcare disparities within this community, we presume that the significance of social determinants of health and sort of healthcare reforms and structural changes will likely be more pronounced for these communities. For example, some differences have been highlighted, like the fact that male sex was associated with greater risk of dementia in certain Indigenous study cohorts, which is very different from what we kind of generally know, that 2/3 of dementia population residing in the United States are women. And these differences likely are related to issues like survival bias, or maybe greater exposure of men to other lifestyle and social risk factors that might include heavy alcohol use, history of police custody, incarceration, stress, trauma, unrecognized mental health risks, and low education. And I think experiences of trauma and discrimination can really confer greater risk for Alzheimer's disease in certain communities. The relationship between depression and dementia, especially, dementia used to be called the pseudo-dementia, something that we know can impact the cognitive health of older adults, especially if depression is severe and if it's not addressed. But much less has been known over time about the association between different mental health or mood conditions and dementia risk within Asian American or NHOPI communities. We do know, however, that the prevalence of depression and other mental health conditions is higher, at least in Native Hawaiians who reside in Hawaii, at about 4.8%, and it is twice as high as the state prevalence altogether, and 3 times as high as for prevalence in Asians who reside in Hawaii. Now that we went over the general population description, I wanted to kind of tailor this assessment because I'm a clinician. And I always want to tailor the talks that I give around what are some of the important, knowing all this literature, how do we actually put it to work when we conduct dementia assessments? And so these slides include sort of some general statistics, but also I wanted to really highlight the voices from the community from this fantastic qualitative study that was conducted on sort of perception of dementia as well as structural healthcare barriers in the Asian American and Native Hawaiian and other Pacific Islander populations. So I'll be including these quotes that you're seeing on the right, directly taken from that paper. So the first issue that is, I think, the most evident and that I get a lot of questions about as a neuropsychologist are, what do we do with the language barriers, as well as how do we actually account for acculturation, given that acculturation is a very complex construct that doesn't actually have a single scale for measurement. And while there are no definitive answers to this, I do think that it's for us as clinicians, it's important to collect detailed linguistic and social history, including, for example, history of immigration, if it's relevant, acculturation experiences, how difficult it is for people to engage, have they been able to make friends, are they able to interact with anyone outside of their family? All of those factors are important because I think they confer potential risk and potential targets for intervention. A lot of the older Chinese older adults that I see in our clinic who are first generation immigrants actually do not endorse when you ask them, do you think you're depressed? Do you think you have low mood? They say, no, I'm perfectly fine. But then when they talk about their actual experiences, oh, actually, I'm very lonely. All of my friends are in China. I'm actually unable to kind of make connections with anyone. I'm worried about going to the store because I'm afraid they won't understand me. And so I think these are all important clinical pieces for us to be able to collect through, at the same time, building trust that, you are the provider who might hear them out and actually help them navigate the system. Interpreter services, of course, are essential for many of the patients that we work with, but healthcare providers should also educate themselves about the cultural and social norms, as well as patient and family preferences that differ widely within communities. And also, I think one of the critical pieces for my work is developing and maintaining a professional network of resources and referral services. I want to be able to know which community healthcare organization I can refer my, Mandarin speaking patients to, my Vietnamese patients speaking to. I also want to be able to know that, if they need a cardiologist who speaks a certain language, I want to keep those networks alive so that I'm always able to kind of connect with somebody who can help me provide better care for this patient. And a quote here that I'm not going to go into, but I think it basically highlights how important it is to be a physician that a patient can be comfortable with. And I think we can do a lot more in terms of our own education, as well as education of our trainees, to provide this level of care. Another kind of group of factors that we want to consider are health and healthcare literacy. As I mentioned before, these include, for example, issues related to navigating insurance, understanding, what insurance pays for, how does insurance work in the United States, as well as attitudes and perceptions of dementia between different communities. These are some of the findings from the survey conducted by the Alzheimer's Association nationally, which found that more than half of Asian Americans believe that significant loss of memory or cognitive ability is a normal part of aging. This is somewhere where we as physicians can really intervene, and we can provide a lot more education about what is normal aging and what is not normal aging, and how do you seek care for when you're concerned. At the same time, about half of Asian Americans say that they're concerned about developing Alzheimer's disease and dementia. So provided support, I think I want to distinguish between some of the narratives that, for example, say, oh, patients don't want to be seen, they do want to get assessments, they don't really care about dementia. But I think they do care. I think it's more about the lack of the education and support and scaffolding about understanding this very complex diagnosis that we as physicians, again, can provide. And finally, experiences of discrimination and structural barriers are very important for us to be aware of and hopefully address both through our research and clinical work. I think this was a really kind of, to me, eye-opening finding from that national survey by Alzheimer's Association, where almost half of Asian Americans believe that medical research is biased against people of color, including themselves. And only 12% of Asian Americans reported that they have no barriers to excellent Alzheimer's disease and dementia care. And I think this is once again just another source of evidence to highlight that model minority myth and that idea that, if you're well off, if your family are well off, you don't really experience health disparities, you know how to navigate the system, and you are not underrepresented in research or in the scientific evidence that we use in order to make these decisions around healthcare policies. And so finally, in terms of actual considerations for cognitive assessments, I won't be able to go into too much detail, but I wanted to provide just a general overview of the most commonly used instruments and the types of tools that have been culturally validated, at least to some point, to assess cognitive impairment in ADRD among primarily Asian American populations. As I mentioned before, unfortunately, there are no known tools that have been adapted to languages spoken among the Native Hawaiians or Pacific Islanders. But based on the review of literature, among the most commonly used tools are, of course, the Middle Mental State Examination, or MMSE, the Montreal Cognitive Assessment, or the MoCA, and the Cognitive Ability Screening Instrument, or the CASI. I'll give you a very brief overview of what these tools are and sort of how, what are some of the pros and cons, or some of the strengths or weaknesses when you consider using them in your practice. So the MMSE is probably the most commonly used dementia screener, both in the United States and globally. It's a 30-item scale. It has known educational effects. And unfortunately, when you start working with MMSE across different populations, you realize that those published cutoffs actually vary widely. In different populations, a different cutoff score was suggested. So it sometimes takes a lot of time to sort of go through the literature and try to identify what specific cutoff you should be using. Another potential drawback to using MMSE is that it is copyrighted, and so there are versions available in different languages, like the languages mentioned here. These are sort of the official publisher vetted versions of the MMSE, and they include, the languages that are highlighted include languages spoken by Asian American communities. So it includes a Hindi version and also a simplified Chinese version, which again is, it's great that they have a version, but it kind of, it's not applicable to many of the Chinese-speaking participants, especially in the Bay Area, who do not read simplified script and might only know the traditional Chinese script. MoCA is another tool that has been developed by Canadian researchers. It's a 30-item scale, similar to MMSE. Unfortunately, it has even more pronounced educational effects because it includes some of the measures that require, for example, speeded generation of words, or quoting numbers back and forth, and the educational effects are very pronounced. And a lot of research studies, as well as different clinics, decide not to use the MoCA because when they serve a lot of patients who have a very low educational background, because it can be very biased against them. Other papers have found that there is a racial and cultural bias in the cutoff. So if you use the same cutoff as you use for example, highly educated non-Hispanic white participants, that cutoff actually doesn't work very well and has very, very low specificity in Black Americans, in Hispanic Americans, and Asian Americans. And MoCA also requires training and certification for certain settings. So if you're interested, again, check out their website, and they have they list all of the different languages to which MoCA has been translated, as well as very helpfully point to the validation studies that you can read on like PubMed. And then finally, CASI is one of the kind of probably least known instruments, but is used very widely in research conducted with Asian Americans. It's a 25-item scale. It includes a 100-point score. And the cutoffs are based on educational attainment, and the tool was originally developed to conduct studies in Japanese Americans, and it was later adapted to Chinese dialects as well as to Brazilian versions. There are many different versions now, but one of the strengths of the CASI is that it includes both an English version and, for example, a Mandarin version, and research has shown that these versions are equivalent. In terms of interpretation of different findings on these instruments, it's important to keep in mind those biases that I mentioned to you before, and kind of, use your clinical judgment when you try to identify impairment. None of these tools really provide you a 100% black or white sort of biomarker style interpretation. So on the MMSE, for example, we know that there are certain language differences in the way that the test has been constructed. Like one of the items on MMSE asks you to repeat the phrase, no ifs, ands, or buts. And in research conducted in Hawaii, over 60% of Asian Americans, regardless of their cognitive status, whether they were clinically normal or not, were unable to repeat this phrase. As I mentioned before, there are highly variable cutoffs. For example, the lowest cutoff that has been reported in rural China was 17 on the MMSE, which, if you use the sort of traditional US-based cutoff, would basically presume that somebody has severe dementia. But that's the cutoff that was found to be most sensitive within the rural Chinese community. And unfortunately, limited normative data and validation studies, specifically within Asian Americans, have been conducted. And most of the kind of research that I'm telling you about and the cutoffs have been reported in Asian populations who are residing in Asia. That's the ultimate limitation of using the tools that unfortunately do not have a lot of participants to be enrolled in the studies conducted in the US for us to be able to make meaningful conclusions. So when you work with the MoCA, you have to keep in mind that there are many, many different forms of the MoCA with linguistic modifications available for different populations. For example, if you go into the MoCA website, you'll find that there are 12 different forms for Chinese speakers. And you need to use your best clinical judgment and your knowledge of the patient to know which form to use. There also have been many alterations made to certain subtests of the MoCA. As I mentioned before, one of the tests, for example, requires you to generate words starting with a certain letter, but many Asian languages do not have an alphabetic. For example, Chinese or Vietnamese are not alphabetic languages. So you cannot really generate anything based on a letter because letters don't make any sense. Just like with MMSE, similar issues with different cutoffs as well as limited normative data are unfortunately the case for the MoCA as well. CASI, as I mentioned before, is an instrument that draws from different scales that have been developed before the CASI, and it draws from the MMSE, the Modified Mini-Mental State Test, and the Hasegawa Dementia Screening Scale. So all of these scores can actually be generated by conducting CASI, which makes it so good for research because we can generate an MMSE score as well as the overall CASI score. And the cutoff scores on the CASI are based on educational groups in a Taiwanese sample, which actually also has found that CASI not only can be administered to people with very low educational attainment, but it also tracks with the disease severity quite well compared to other scales. And again, another thing that makes CASI somewhat perhaps more applicable to certain populations is the fact that because it was developed specifically to work in the Asian American groups in the US, it was culturally tailored. And for example, when you ask somebody about the date of their birth, or the date currently, both solar and lunar year dates are accepted as correct. And I just wanted to highlight here, this is just an example of Chinese, primarily because Chinese remain the largest ethnic group in the United States. But it's very, very important for us to understand the diversity of not just spoken, but also written language in certain communities, where depending on sort of where you live in the world and where your family migrated from, or if you have a patient who is an immigrant from a certain part of the world, they might be using a different written and spoken style or dialect of Chinese. And so you want to be able to tailor your assessment as well as your interpreter services to match the patient's background. You won't believe how many times I have had a patient who spoke Mandarin and I got a Cantonese interpreter, and I did not know what to do because I don't speak either language. These are just some highlights. I think I'm gonna kind of very briefly mention that, these are just some references on the general kind of population and the description of the population of Asian Americans and Native Hawaiians and Pacific Islanders in California specifically. And I also wanted to highlight the research that I do on specifically documenting those disparities that we talked about. So we know that at least in California, Asian Medicare beneficiaries are significantly less likely to receive a timely diagnosis of ADRD, meaning that they are diagnosed at later stages, and also are less likely to receive a comprehensive dementia diagnostic assessment, meaning that they receive poorer quality of care. And the next few slides are just research opportunities and resources that I'm hoping would be helpful to you, or maybe to people you work with, where, if you want to kind of point your patients or your colleagues in the direction of where they can find resources about the Asian American and NHOPI communities, you can always reference Alzheimer's Association. They have this very nice page around the general population in the United States, their risks for dementia, as well as different types of resources that you can provide, for example, for caregivers or families. The research opportunities include, different types of cohort studies that actually have been ramping up lately, probably because NIH read that 0.17% of budget summary from previous studies. And there are now studies that specifically focus on Asian American populations, specifically as it relates to Alzheimer's disease, and tries to understand, whether there are genetic, ancestral, social, behavioral, or other clinical factors that confer different risk. So this is one of the largest studies called ACAD. UCSF is a site for ACAD. So if you have a patient or, somebody who would like to be interested, please point them in this direction. Another fantastic study with one of my collaborators is a Vietnamese Insights into Aging program. And it is the primary investigator is at UC Davis, but they enroll at sites across the Bay Area. So this is another great opportunity to engage people in research if they're interested. This is a super busy slide, but I just wanted to highlight that if you have any questions or if you would like to engage in research, our group has a lot of studies, and we're building out more and more sort of support around both engagement and research, but also clinical care and, potential community services for the Asian American population residing in the Bay Area. So please feel free to go to memory.ucsef.edu and you can find a lot more resources there. These are just my take-home points, and I think I will stop right here. You can read these, and I'm more than happy to take questions. I'm so sorry I went over time.
No, that was a tour de force, but I think really worth it. And you certainly, I think, left us all much better informed about the state of the science, and gave us ways to think about all this diversity and some hope that it's getting better accomplished in terms of our understanding, because it really is overwhelming. That 0.17% number was absolutely jaw-dropping in a really horrifying way. And I don't know, I learned so much. So I think we're all really grateful. And because that was such a tour de force, I think we only have a millisecond for some information. I want to point out to everybody, the CME information is in the chat. It will get emailed to you if you registered, which I believe you had to do to be here. And I will put up some more CME information and let you guys get to it. I'm gonna ask you one question because that's what we have, but it was a really good question. It was our last question about if we're working clinically, right? We have this really diverse population and we want to ask and get some sense of people's work experience, education, immigration experience. Any tips or tricks or openers? I'm sure you're doing this all the time to contextualize your assessments about how we would do that in a sensitive and appropriate way, because clearly people are from very diverse backgrounds. And as you point out, there's a lot of history there, some of which is very traumatizing and, or, has a lot to do with personal trauma.
Mm-hmm. This is a fantastic question. I think it has a lot to do with sort of the way that we also think about, personal, like people's perception of healthcare. I do think it's incredibly important to first establish rapport. Even like as a neuropsychologist, I always ask people, how far did you go in school, right? It's important for me because that's how I understand my results. But I think being sensitive around not asking that question right away, because it can, make a person feel like, oh, is she judging me based on, how I speak, or is it my accent, and people really try, you kind of see that reaction of, actually I'm very smart, and, my daughter went to medical school. And I think those are all very important things to be aware of. And so I think rapport building and trust building is probably one of the first important steps to establish. And I think you can gauge somebody's experience. I like asking, is it okay if I ask about this? And I think, patients are more than welcome to say no, we can collect this data later. But I think the more you kind of provide education and the more you can, for example, educate your patient to say, there are a lot of factors that can impact how sharp people feel, how good is their brain health? And those are some of the questions that I want to ask you today. So I think that would be kind of my little clinical.
Yeah, that's a wonderful pearl, like some context and a reason. So they don't just feel like you're profiling them and kind of, being insensitive. Okay, that's a fabulous tip. And then I'll leave it with the last comment, which is that to point out that I guess a lot of folks, their age may not actually be true in their medical record. So to keep that in mind and maybe also contextualize that and say, would it be okay to ask to see if your birth date is accurate?
Absolutely. I think this is such a huge issue, especially with like immigrant communities, especially for people who immigrated as refugees, I think, because they immigrated with no documents, right? And then they might not have used the same calendar system or have not relied on the calendar as much as we do now. So I oftentimes see the lunar calendar, sort of, you kind of see like somebody's age just being the lunar calendar year that they knew they were alive, and that would be their date of birth. So I think it's very important for us to be attentive to those types of issues. And again, I think engaging the family members early on and kind of making sure that it's not just the patient, right? Their caregivers also need to be aware that there are the experiences of their fathers or grandfathers or grandmothers is very different from how they are, because usually the children are sort of they're born in the US, so they're very acclimated to the US culture. And so I think as a provider, sometimes we need to be that connection to basically say, oh, by the way, there are actually very, very important things like social, economic, environments in which your mom grew up in that I would really like to know. And, it's important for all of us to be on the same page about it.
Thank you so much. I will let you go, but Dr. Tsoy, thank you so much. This was an incredible presentation. I think we all learned a lot.
Thank you all very much.